So first of all, just as a bit of an introduction, really, without planning it, I've ended up shifting most of my HIV work to COVID-19 over the last few months. And that's involved tracking the research and the science and treatments. And so IBASE has been putting out, we're now on the third issue of a bulletin called HIV and COVID-19. And it picks up what looks like, to me, the most important bits of research and science. And this is changing really rapidly. So I put the last bulletin out last week, and already I've got enough content to fill another issue. And I just thought, I learned most of don't have a science background, but I learned most of my science through EATG meetings and ECAB meetings, and all those skills are just as important now in this sort of pandemic where there's no effective treatment and there's all sorts of misinformation going on there, and so I found it quite easy to track this research critically, and I thought it might be useful just as the EAT colleagues just to go through this, see how you're doing, make this more of a discussion than a talk or lecture. I'd probably talk for about half an hour or something like that through just a few slides, but you can stop me at any time, and we can take questions as we go along, and then have plenty of time to talk at the end as well, if that's okay. The slides will be online as well. So that was sort of the introduction, and really I've been spending time doing this because it's the best way of helping us and other people living with HIV to understand what's involved with COVID-19 and how important it is for us. How do we differ from the general population, and to do that sort of critically to the news. And so as background, I guess, everything that we started off knowing about COVID-19 came from China. That's where the first health epidemic started. And so early this year, in January and February, we were getting quite comprehensive reports of how the epidemic played out in China. And the main things that we knew were that in 80% of cases, it's mild and moderate, maybe don't even need hospitalization. 15% were hospitalized, and 5% of people had this sort of, really critical chronic infection that had a high mortality. And then top slide on the top right here basically showed the age distribution, in that it was adults were getting infected, but this yellow line here is the shocking one, and that as your age went up, as age gets higher, particularly once you're over 60 or 70 and especially over 80, then the mortality rate, your risk of coming out of hospital once you got into hospital, became much lower, much higher mortality rate. Down here, we had like a list of common symptoms that were reported. It didn't seem to make much difference whether you ended up having severe or mild disease. In terms of the symptoms were pretty much the same. Not everyone got fever, although fever was the distinguishing mark. And everybody thought that this is just a version of influenza, and it's turned out to be far more serious and far more complicated. And so the first thing, I guess, is that the epidemiology, the numbers of people that are being infected is being recorded in more detail than any other infection that I can remember. And so the first link here, this is based on a talk I gave to the UK CAB a couple of weeks ago. That's just the UK data, and probably all your countries have got similar resources there. WHO produces a daily report that includes all countries. Johns Hopkins does a similar service. There's a website called Worldometer, which presents the data in different ways. But you could click on this now, and you would have, sort of similar estimates from these different sources. And that we're, at the moment, we're in more than 4.5 million infections, and over 300,000 people have died. But the detail that's here is the important thing. And when you're analysing the data, you don't just want to look at the key numbers, the numbers of people infected. You want to look, per 100,000 or per million population in terms of comparing different countries. UK is doing particularly badly. Some people in the UK say that's because we record data. We're lucky that we have very good data recording systems, but I don't think that's the whole picture. There's over 30,000 people have died so far. So the first studies that we included were real basic ones about transmission, and there was a complete vacuum really of accurate information. But the most quoted study, which was used for developing references for reducing the risk of transmission in terms of keeping your distance and hand washing and not touching your face, came from this first study up here, where researchers took SARS-1 and SARS-2, and they did a set of experiments and found out how infectious surfaces were with the droplets. And so the main conclusion was that if it lands on hard surfaces like metal, it stays in more infectious for a long time. And that covers things like door handles, but less reported was the fact that the volume of infectiousness also drops quite dramatically over the first few days. There was this median incubation time, which is, how long does it go from infection to having symptoms when you might be able to test to see whether you're infected or not. And the 5 days is usually quoted. If you're unlucky and you catch coronavirus, then within 4 or 5 days is when you'd expect to be seeing symptoms. But as with all data, you want to see the range that different people experience, and some people might go 2 weeks without symptoms, and occasionally you get people go 3 weeks without symptoms. So this caution about how safe you are, depending on what your behavior has been over the last few weeks, needs to allow for the fact that you might take longer to get symptoms. And some people don't get symptoms at all. These 4 papers gave an idea of the risk of transmission. Our highest risk is living with someone who's diagnosed with COVID-19, more than sharing public spaces. And then there was a really good report from Mark Mascalini from NATAP, reporting a study which was the first one to probably highlight that just regular speaking, when you speak, droplets of infectious droplets just come out. It's not just sneezing, it's not just coughing, even though coughing and sneezing produce far more infectious material. If you're just sitting in the same room with someone for a long time, that air will be contaminated with infectious droplets. And then a note on that really is one of the best sources of information is NATAP. And I haven't gone digging around looking for any of these studies. They've all come through, treatment lists I'm on, or table of contents for the main journals, New England Journal, Lancet, and things like that. And then early on, people were talking about sexual transmission, and our background working in sexual health and HIV as infectious disease means that was an early question. And probably the organisations that led by saying this isn't a time to hook up or find new partners are giving the best advice, certainly until we get through the first few months and understand what's happening. And then as people dig around and want more information about what is the risk from sexual transmission, the implication is to think about sexual fluids, but that's not the mechanism. The mechanism will come from saliva. This is a throat infection, so viral load in saliva is the source of the infection, and heavier breathing in a confined space, I think, are much more important risks than whether a sexual fluid is infectious. Are there any questions? Shall I carry on? Am I talking slowly enough?
No questions on the chat system.
Great.
I don't know if anyone else has questions. You can unmute yourself if you have a question. No, I think we can carry on.
Cool. So this is the slide about viral shedding, and as the symptoms, just like with HIV, if you well, actually it's not quite like HIV. If with HIV you can only test using viral load, the PCR test, once you've got circulating virus in your body. And so as a throat infection, coronavirus is tested by a throat swab, and then they do a viral load test. And you can see here that as symptoms occur, as you starting to get symptoms, that's when viral load probably tends to be highest. But also there was interesting studies showing that having symptoms or not was not related to whether or not you were infectious. So you can not have symptoms and still be just as infectious. So we got this really difficult situation where you might become infected without knowing it, not have symptoms, and still be infectious. Average length of time, 5 days after infection, but maybe 2 weeks after infection. This is a really tough public health problem. So in the UK, symptoms were managed. You know, we have a population of 60 million people, and we have a national health service, and so information has gone online. And there's also been a free phone number where you can just call and go through your symptoms and see whether that's likely to mean you're at risk from coronavirus. It doesn't always get it right. So there's been cases where people have been missed. And the two key indicators were high temperature and a new continuous cough, like a dry cough. And then yesterday in the UK, they added taste and smell changes about a month after we reported that in IBASE. So this delay in information is also why it's good to be taking a treatment activist approach to coronavirus. So this was the earlier slide, enlarged a little bit, and you can see that the different colour bars are mild, severe and critical. And so the critical is where you've got the high risk of mortality. And there's not a difference pattern in initial symptoms, depending on what's going to happen. So you can't tell from how severe your symptoms are, how severe COVID-19 is going to become. This is all data from China. And that's the taste changes that came on in the UK yesterday. So the other outcome from having to deal with so many people that are likely to be infected with coronavirus was that this was going to overwhelm the NHS, overwhelm the healthcare systems, and as a default, many people stopped using, even if they had serious problems, suspected heart attack or stroke or something, they pulled back from using the NHS. And partly that was to do with self-isolation, and partly it was to do with concern for the NHS, and partly it was just not good information, I guess. So again, very early on, we included this, which was I'm not even sure if it was. I think it was published study. I think it was in a heart journal, and it was a proposed staging of COVID-19. And so when this was published, people were still talking about this being like influenza and being a lung infection or throat infection, and it's clearly not. So you have the first stages. These are proposed 3 stages, really. The first stage is where you have the initial symptoms, and the infection is really in your throat. And the second stage is where just from breathing, you take the virus further down into your body and it becomes a lung infection. And then the body's response to the lung infection starts blocking up the airways and the alveoli in the lungs, which is where oxygen comes through the lungs and then filters through this light whipped cream foamy tissue into your blood, and you're well oxygenated. Oxygen goes around your body, and COVID-19 blocks up your lungs with dead cells and waste deposits as a response of your body trying to fight the virus. And at this time, it changes from a viral infection to being a disease related to inflammation. So you probably heard on the news when they talk about cytokine storm, and that's your body producing all these inflammation chemicals, and it changes from being a viral infection to immune inflammation. Similar to the way HIV causes inflammation as well. And then if you're really unlucky, then it progresses to a third stage, which is where it's not just the lack of oxygen in your body, in your blood that's becoming a problem, but it looks like all the major organs could be involved. So there's been case reports of it affecting your brain, affecting your liver, affecting kidneys. Certainly blood clotting is really common, where they've looked at tissue afterwards and found blood clots in the lungs. And so some early studies are suggesting that anticoagulation therapy is going to be a good thing, or might be a helpful thing. So risk factors, again from the first slide, the things that jumped out, perhaps people didn't realize exactly how serious it was, I guess, is that the big risk factors were older age, particularly over 60 or 70, with male sex was more affected than women. Not sure whether that's because of social factors, like data coming from China. There's a big difference between the numbers of men who smoke compared to the numbers of women who smoke. And there's a list of some of the other problems that have started. There's also been studies highlighting that related risk factors like high BMI or being obese is related to a worse outcome if you catch coronavirus. It's all sounding pretty gloomy. This was a slide from earlier again that just showed case fatality and distribution by ages, but now this might be social factors and early isolation that just protected children early on. So the first questions I wanted to know what happened to HIV positive people. And even though this virus had been around for several months by this time, there was very little data, direct data that said what happens if you're HIV positive. And you had various statements, optimistic statements really, from Beaver and EATG saying we hope that it's going to be the same, similar as general population if you're HIV positive, so long as you're on treatment and you've got an undetectable viral load. And the two things we have to worry about there is not everybody is undetectable, and that we also, amongst the populations affected by HIV, a lot of us have comorbidities and histories of heart disease, and we're getting older, and a fair number of us are men too. So knowing that your risk is the same as the general population, and you see 30,000 people have died from the general population in your country, isn't necessarily so calming. And then people who are not yet diagnosed will be the highest risk, I would guess. And the first few reports that came through, the first report came through from China, which was, I was really impressed actually, is that Chinese researchers had gone through the medical records of HIV positive people in Wuhan city, which is where the outbreak first started, and they phoned people up and they phoned up 2,000 HIV positive people and just asked them about the symptoms. And so that data was fairly reassuring in that there was less than about a dozen people who had become infected with coronavirus. So it's like it's slowly supporting the fact that HIV itself might not be a problem if you're on treatment. But then the case studies that came through were very small numbers. This was enough to get published. 5 people from the Spanish cohort. And the proportion of people was roughly the same as the proportion of HIV in the general population. There was a large New York cohort where I think out of about 6,000 people, about 40 were HIV positive. So it's sort of similar percentage to the background population, but nothing really specific. This wasn't reporting people's CD4 counts or what treatment they were on. And very early on, you had suggestions that HIV treatment might be protective in some way. So that's why most of the reports you read about COVID-19 treatment from the first few months have people using Kaletra, even though when they studied it properly, there's no benefit from using Kaletra. So the consensus is now that if your CD4 count is above 200 and on treatment, undetectable viral load, your risk is the same as the general population. And as these things change, particularly as you get a lower CD4 count, then your risks are expected to become much higher. Coronavirus will knock your CD4 count. Even if it's just for a short period, it will at least halve it. So if you start off with a low CD4 count, there's also questions about risk when coronavirus knocks this down. So as somebody who follows HIV treatment guidelines, The biggest surprise from all the guidelines that have come out is none of them talk about treatment. There's not a recommended first-line treatment in expert guidelines about coronavirus and COVID-19. The top one, which is the US, one of the US panels of guidelines, it's got 7 options for treatment, and they all have the same subline underneath. Says there's no data to show whether this is effective or not, and it should only be used in context of a clinical trial. And so as people who are used to keeping up to date with HIV treatment by referencing guidelines, the lack of mentions, I can't find anything in the UK which has been published for how an intensive care unit should manage treatment for somebody with COVID-19. I think this is a huge gap. Can't find many doctors that talk about it either. So if you look at the research that's going on, you know, I always go to clinicaltrials.gov. It's the best, it's the biggest registry. It's not just US studies, lots of European studies, most European studies actually are registered there. And they've got a fantastic search facility. So you just search COVID-19 and the treatment you're looking for, you just search COVID-19 and you'll get more than 6,000 studies and 1,600 studies. And there'll be a mix of treatment and prevention, but it's a really good, if you're looking to do research, this is a really good place to start. The information is only as up to date as the people running the studies post there. My first impression is that research is a huge mess. People are just grasping at anything that might help. There's a huge amount of duplication on compounds that don't look particularly good. There's still studies up there with the Kaletra, so HIV drugs are included. There was I'll talk about some of these options in a minute, but there's remdesivir is the antiviral that is supposed to have direct activity against coronavirus. But you have all sorts of experimental treatments going on with different types of drugs. And now they're starting to look at not the virus, but trying to treat the inflammation. And I think that's more likely to be successful. So you can't not have heard about remdesivir. If you're following the news, if you're on any of the treatment forums, this is a compound, sorry, is now a drug because it's been approved. Gilead had this when they were researching treatments for Ebola virus, and it didn't do as well as monoclonal antibodies, so it didn't get developed. But it's active in the test tube against this whole range of viruses like SARS and MERS and the coronavirus that's associated, that causes COVID-19. So it's active in the test tubes. But then there's been a real mess about how we know whether it works or not. And given it's been in studies for over 4 months now, and you're talking about something which has very short activity. You know, each of those stages for COVID-19 lasts about a week of symptoms when it's a throat infection, another week when it's an upper lung infection, and then another week if it progresses to serious complications affecting other organs.
Excuse me, Simon, there's a question from Gus, or a comment. He's asking about interferon and ribavirin, study in Lancet with Kaletra. Interesting because it was what we used to use against HCV. So
I mentioned that in a minute in the list of the compounds that are being used. And the shocking thing I found about that study was the conclusion that combination therapy contributed to the results, when actually we already know that Kaletra didn't contribute anything to the results. And so I don't understand it. This is the Lancet, and it lets the conclusion go through that combination therapy is important when you already know other studies would not come to that conclusion. But thanks for bringing that up. That's good. I'll mention it very briefly as well. So where we're getting data about remdesivir, and this is becoming politicized, you know, you've got the US president with 70,000, 80,000 deaths now in the US. Nonsense, a non-science-based approach. And I think that they are desperately looking for something that will work, but all the first published data from compassionate access, you couldn't tell whether or not remdesivir was helping, because some people who got it didn't get better, and some people who got it did get better, and some people would have got better without it anyway. And then on the 29th of April, you had this paper published on the WHO website and then quickly taken down, which summarized the study as showing no evidence. It was then rapidly published in the Lancet, and at the same time, the top line results from 2 other ongoing studies were, Anthony Fauci in the White House, sitting on a sofa, gave the results of this study. Crazy. And they didn't say much. They just said that it was placebo controlled and actually people got better. They recovered a bit better earlier if they had access to if they were using remdesivir. And then this Gilead simple study, this is comparing 5 days versus 10 days worth of treatment with no other control arm, no placebo arm. So the fact that these did exactly the same, you can't tell really what happens at all. And on the basis of this, Gilead have ramped up production. They said there's going to be 500,000 sets of treatment available. They've signed licensing agreements with generic manufacturers, and we still haven't had a solid published study that shows exactly how well it works. This is the Chinese study that was was released on the WHO website and then published in the Lancet. And I'm not a scientist. This is an antiviral drug, and these 2 slides are viral load in throat and viral load in lung tissue. And I can't remember what the colors are. So remdesivir is the red line, and the placebo. This is a real placebo, genuine placebo-controlled study. And so it's been randomized, and nobody knows who got what. And these drops in viral load do not point to any direct antiviral activity of remdesivir. So I can't explain it. Since then, it's been approved on emergency access in the US. But if you read the guide, you read how it's approved, basically it's approved because we have nothing else. There's 3 reasons. 1 says because we're in the middle of a medical crisis. 2, we have nothing else. And 3, we think it might work. This is the FDA saying this drug is approved because we think it might work. And the risks that it might work probably balance the risks that it won't. Something must be working. In the other US study, people got better a bit earlier, but I don't understand this lack of viral impact or how else it would be working. And so the other problem with lots of the studies is that people are only getting access to all these treatments once it's progressed to becoming serious enough to be hospitalized. And so maybe all these treatments are being used too late. So you self-manage and you self-isolate at home, and then if your breathing becomes more complicated, your fever goes up, then you go to hospital, and by that time you're already 2 weeks into this viral infection. You've progressed to the 2nd stage, and maybe antivirals would have been useful if you took them much earlier on. Okay. So the other drug that got lots of publicity early on was hydroxychloroquine, used with an antibiotic called azithromycin. And hydroxychloroquine is an antimalaria drug. And the fuss was caused, or the interest was caused, by a small study in France by Guattari, and it had all sorts of problems if you try and find out what the data was. It was an open label study, so there was no control arm. Very soon afterwards, French researcher that we all know really well, which is Jean-Michel Molina, who did the IPAGAY study, is convinced this is not useful for anyone, it's not working. And so he had a set of case studies that showed no benefit of this combination. And yet if you search clinicaltrials.gov for ongoing studies, you will find dozens of them, maybe 50 studies are going ahead trying this. So this is controversial. There's controversial lack of evidence. You probably all saw President Trump on TV yesterday saying, I'm going to take it anyway. And the downside is it might have heart problems. So these are links to some of the other studies that I've covered. which we're already getting some data on. So this is a monoclonal antibody here that reduces targets IL-6, and one of the inflammation markers that goes sky high when you have COVID-19 is IL-6, and so this might be this is being used in Japan. It's being used in other countries. There's early data showing this might be more of a useful target. And then there's other articles here. There's rheumatoid arthritis drugs, the anakinra, it targets the inflammation, and so they've got a small report of this being used in COVID-19. There's lots of interest about convalescent plasma. That's basically somebody who's had coronavirus and they've come out the other side and they've done okay, and you take a plasma sample and use that as a treatment for somebody who's undergoing symptoms. There's early data showing this is interesting and maybe a safer approach. And then the study that Gus mentioned here actually is a different study. It's not the Lancet one because I was so annoyed at their conclusion. But I put another one in. So there's data showing that interferon might have a role, might be useful. All the conclusions of all these studies say that they're generally open label and we need randomized controlled evidence. How am I doing for time? Okay, so I saw a couple of questions about PrEP that came through. One was about whether HIV PrEP would be protective, and that was one of that was a discussion on lots of treatment forums. Is anecdotally, Spanish doctors said they hadn't seen many cases of coronavirus in people taking PrEP. I'm not sure it's going to make any difference actually when you get good data, but that's been enough in order for a large study for healthcare workers to use TDF and FTC here. You can say what's the harm of trying this, and there's data to show that TDF and FTC have anti-coronavirus activity in test tubes, and that this might be useful to test. But this is 4,000 health workers who might go into 2 arms of a study or 3 arms of a study with nothing that's active. And so the downside for going into one study is that you're probably not going into another, or that you won't be using other options that might be more effective as prevention. And so PrEP for health workers, lots of studies are listed on clinicaltrials.gov. They include most of the things that are being looked at for treatment as well. And whether or not these have any activity is difficult to say. I'm not very hopeful actually. I think the approach to coronavirus was to try and repurpose anything that might have a chance of working. And then there's 12 studies looking at BCG, giving health workers BCG vaccine on the theoretical hope that it might provide protection, like a broad antiviral protection. And then a couple of days ago, this Israeli study was compared people who had BCG vaccination in childhood compared to people who didn't. They had a good population for studying this, and they saw no lasting benefit, no benefit in terms of risk of coronavirus. I just put this in because this has been controversial since as a public health option, I guess, since coronavirus has been around. And I think you're moving from most countries saying that using masks would have a population-based effect. It might protect you individually, even though most of these articles say it won't protect you individually, but it does protect other people around you. If you don't get to your sleeve quite quick enough when you sneeze or cough. I think it also sends out like a social message that you're aware of what's going on. And so it's good to see that there's some evidence that supports this. Huge amounts of information online. Information overload is probably the problem. If you start, if you read too much, you will just go a little bit crazy. But the WHO has got some good resources online. The IAS is doing very good webinars, getting maybe 400 or 500 people attending each time. They're being led by really good HIV doctors who are being they're being moved to deal with coronavirus, certainly in the UK, and I would imagine most other countries too. And so some of the faces will be familiar in terms of getting information about COVID-19. Like I said, we do this bulletin now that comes out every 3 or 4 weeks. And I thought it's worth mentioning NATAP because they do such a good job at just ignoring copyright and putting everything online for HIV. Interestingly, for coronavirus, all the medical journals have made everything open access. So actually it's a fantastic time to be learning about this stuff. And that's the slides, end of the slides.
Thank you, Simon.
So I'll stop sharing this and see everyone.
Thank you, Simon. And anyone with questions or like to share anything, please unmute your mic. Okay, Gus.
Yeah, I wanted to say a little bit more about the interferon and ribavirin study because I thought it was actually more promising than that. I think you can discount the Kaletra. I think basically the fact that they used the Kaletra as the control, Kaletra solo as the control arm implies that they didn't think it would do anything but felt they couldn't do nothing. It was a study of interferon and ribavirin. And that was really interesting because the viral load was 1.5 logs lower. Time in hospital was 9 days compared to 14 days. It's probably the only study I've yet seen where I've seen really convincingly different results for the trial arm. It's only one study. It was in Hong Kong, and important to emphasize, it was in moderately badly affected people. It was people who were hospitalized but not critical. But I just found it interesting.
No, it's great. All good points, mate. You might be right. Given that horrible drugs to take. but you might be right.
Yeah, it's a horrible virus to have. So,
so all our experience over sort of ethical approaches to treatment and research are just as important for coronavirus. All these studies are being designed largely without community input in the design groups. None of the Gilead remdesivir studies had community involvement in planning this stuff. And you've got ethics of just like early HIV, ethics of placebo-controlled studies, which is really what you want to know whether it works, and the ethics of not giving somebody something that might work when they're in a critical health situation. And so, it's never been a better time to be a treatment activist because there's a real need out there in terms of interpreting all this information overload that we get all day on the news.
Thank you. There's also a question from Julio.
Yep.
He asks, can we talk about how the fact that HIV doctors are switching to COVID-19, will this affect HIV care? Maybe it is off topic.
So I don't think it's off topic at all. I think everything that's related to HIV and coronavirus is on topic. And one of the first things that happened in the UK was that routine health services for practically everything else got shut down. Appointments for all sorts of other health issues that you had got cancelled. HIV appointments got cancelled. The HIV consultations still go on, but they got moved to telephone consultations or virtual consultations. Probably, this might be an outcome which is much better in that you can actually get to talk to your doctor immediately, much quicker than I could ever get an appointment before. But then there will be less doctors working on HIV. So I don't know what's the situation in Italy where we had Italy as an example. We also had China as an example, but we had Italy as an example. Exactly 3 weeks, everything that happened in Italy happened in the UK. And so we could have learned from that experience. How are things in Italy, Giulio?
Well, they are more or less as you described them. Most of the appointments have been delayed until the end of the emergency. So many people living with HIV cannot see their doctors if they have no special problem. But I'm most worried about what will happen after the emergency, after all. So if the the fact that we missed some appointments with the doctors could be considered as something that could be put in place even in the future. And so I'm asking myself what we should do as advocates about this.
So some of the other things that happened in the UK is sexual health services virtually had, they're still going on if you really need a sexual health appointment, but it's by appointment only. There's no drop-in services. And then the other thing that happened is all the lab capacity was shifted from sexual health and HIV. So the reason you're not getting monitored for HIV is because the labs are doing PCR tests for coronavirus. And in fact, some of the home testing kits for HIV that people use in the UK, if you want to get an HIV test, the first way of doing it is you get it posted to you in the post. Those tests have been repurposed for coronavirus. And so there will be a huge backlog of sexual health complications that will be missed because nothing will be done for 6 months, even though it's a time when people should be hooking up less or looking for new partners less. There's going to be, a backlog of all sorts. I think you're right. There will be a backlog of all sorts of things for anybody that's slightly more complicated than having a stable viral load on treatment. And Viva response in terms of starting people, people are still going to be diagnosed with HIV and still need to start treatment, is they've thrown all the guidelines about the cost of drugs out of the window, and they've just said, you want to use a treatment which involves no hepatitis testing, no 5701 testing for abacavir sensitivity, no resistance testing. So UK guidelines now say, if you need to start HIV treatment, use Biktarvy. Bictegravir, TAF, probably the most expensive combination, or not a cheap combination, just because it involves less monitoring. I don't know if you've had the same response in other countries as well.
I've got a couple of questions. Julian has had his hand up, and I've also got the questions from Mark. Julian, do you want to go first? I'll unmute you.
Yes.
Okay, Julian.
Thank you, Simon. As usual, absolutely fabulous. I think one of the other things that we've seen, and I wanted your comment upon it, is that like the early days of the HIV thing, when there wasn't, before antiretrovirals came along, there were all those fake and quacked cures. And I was just thinking, the one I'm thinking of at the moment is the Madagascar cure, which is being trialed by the Max Planck Institute. And I'm just wondering whether you had any views on that, of whether any of these things are going to be of any use at all, or whether it's just a waste of time.
I haven't seen as much coronavirus denial as we saw HIV denial. And I think the answer is you want evidence for anything that might work. You can't do it based on anecdote. And unfortunately, it's not going to be as easy, just like HIV, as finding a herb and boiling it up and make tea. We're dealing with something that's just much more sophisticated, highly pathogenic infection, and there's not going to be something sitting on the shelf. I mean, with HIV, it was the same approach, really. People, researchers, really good researchers, really good doctors who read old AIDS abstracts, if you do that sort of thing in your spare time from early HIV conferences, and Cycler was being repurposed, thalidomide was being repurposed for HIV. The same response is happening for coronavirus, and when this isn't going to be successful, it's a wasted opportunity. People go into, just like with HIV, we all went into those early studies because we trusted our doctors would be doing the right thing for us, and unfortunately, they weren't always doing the right thing for us. They were trying things out of desperation, and yet I had no understanding of what was desperation and what was real science, and so some of this stuff will be sham, I'm sure.
Okay, I've got a comment and a question from Mark. I'll probably read Georgia's comment first. I know it's a question as well. Okay, I'll start with Mark's question. Are there any statistics of false positive or false negative for? Sorry, the questions are coming in first. I'll start again. Are there any statistics of false or positive false positive or false negative COVID-19 diagnosis among people living with HIV?
Good grief, yes. Well, look, I can't say about HIV. It's also fine if people want to put their hand up and just ask the question, so we get to hear you. So testing for coronavirus is complicated. There's just like HIV. It's exactly like HIV. There's two sorts of tests. There's a viral load test to see if you have an active infection, and then which is done from the throat swab, and then there's an antibody test to see whether your immune system has seen the virus, been in touch with the virus, just exactly like HIV. And the first few months of the antibody tests, there's a lot of, certainly in the US, there's a lot of really bad tests out there that were giving false positives and false negatives in the general population. This is no information about HIV specific people. I don't think HIV would be a reason for the tests to perform any differently. So I forget HIV in terms of how effective the tests are, but the early tests were terrible. And I've just seen, some recent tests, one's from Abbott and one's from Roche, both now FDA approved, which have 100% sensitivity. So if you've got the infection, it will accurately say that you've got it, and something like 99.6% specificity, which means if you haven't got it, it will also be an accurate result. But in the first few months, whatever they were using to test was not very sensitive or specific, and so it was a mess. And actually a bad test is worse than no test, because in the UK we had no tests really, but a bad test is worse because it gives you false information about whether you're at risk to other people, or about whether your own health means you should be self-isolating.
Thank you. We've got about 10 minutes before the first hour is out.
Okay.
Giorgio, would you like to ask your question? It's quite long. Would you rather speak and just ask it yourself?
Yes, thank you, Simon. And I was wondering, since you made the point that the clinical trials that have been run for drugs for COVID-19 haven't been kind of monitored by the community, so there were no community representatives in the trial committee. But I was wondering if we could think about any other trial where we could act proactively as a community and reach out and ask whether they would see our group doing some kind of review or participating to being part of the trial committees. Especially, I was wondering whether something was happening in the area of vaccine development.
So the first part of your question, I think getting in touch with independent research that's going on in individual countries, or I don't know how many international studies are being run. I think that it's only things like remdesivir or companies that are developing a product that is likely to be international studies. So most of the research seems to be within country, and so connecting with your local investigators as a community, and you're interested in helping. They probably would be keen to know. Everybody's working in a crisis mode, doing everything yesterday as fast as they can, and so it might not be that we're getting mixed out deliberately, and so the more active we are, I think, in our maybe would help. So I'm now getting sent copies of protocols to review and things, so it makes a bit of a difference. And sorry, and it's the second part, and vaccines. Yes, it's we can be involved in all this stuff. There's at least 8 vaccine candidates that are going into studies now.
Okay, thank you. I think let's ask Rosa to speak first. She's got a question. Rosa, do you want to ask your question, and then Julio? Who's on Galaxy tab? Is that Rosa? Okay.
I asked a question. I already wrote it down.
Yeah, just say it again.
Okay. Are any statistic on people living with HIV with multiple disease like diabetes and heart disease of blood pressure?
So it's a really important question, and we already know that because those are the risk factors for coronavirus, that will increase your risk if you're HIV positive as well. So just our background, health histories means that lots of us are at that risk because we've got heart disease or a history of heart disease. It's active heart disease, not so much a history of heart disease. And so if anything's uncontrolled, if you have high blood pressure that's not controlled, that's going to increase your risk. If you're controlled on medications, that might even be protective. And we've got no data on what happens when you have more than one of these risk factors. If you're older than 60 or 70 and you have active heart disease and you're HIV positive, so the way that all these things come together, we've got no data yet on HIV positive people. The largest cohort on HIV positive people was published in Clinical Infectious Diseases a couple of days ago, and I think that was about 40 HIV positive people.
Thank you, Julio.
Continuing from the UK database, the intensive care database has got over 120 HIV positive people were diagnosed with COVID-19.
Okay, Julio.
Yeah, if I may, I would like to add something about the question raised by Giorgio, because I am involved in the National Ethics Committee for the COVID-19 research in Italy. So I had the opportunity to review most of the consent form and also the protocols, but unfortunately at the community ethics, at the ethics committee level, it is hard to propose for changes in the protocol. It is a later stage. But for the informed consent, it was really a challenge because it is really difficult to advocate for a clear language when the research is so urgent and you must approve the study as soon as possible. And one more comment about the study on vaccine. One of the most important study will be conducted at the HPTN, where I work now, the HIV Vaccine Trial Network, which opened a branch for the COVID-19 research. So I can guarantee that at HPTN there is a huge community involvement, that they are working to understand how each site has works with the local communities. Unfortunately, the study will not happen in Europe. There will be no site in Europe. It's also Northern and Southern America, just to let you know.
So thanks, that's fantastic. It's great to know that's all happening and great that level of involvement as well.
Gus, would you like to talk about your MMR vaccine? You're muted.
No, because it's actually more an example of the kind of highly tenuous research that's been popping up. I gave it more as a sort of warning of the kind of thing that you see popping up all the time about COVID rather than anything else. It's by some independent researcher who used to be a computer scientist. I think that speaks for itself. So really, I mean, if I want to say anything at all, it's and I'm sure Simon will back me up on this, look at the COVID research you see with a really big dose of skepticism and with all the knowledge you've gained from HIV research, to be able to distinguish between what looks like a good promising study and what probably is fake news or people thinking they found something when they haven't.
And Gus, do you know of guidelines for treatment for COVID-19?
Sorry?
Do you know of any treatment guidelines for COVID-19? That actively name, or even in the UK? I mean, I can't find anything in the UK.
I found some very vague ones a while back, and I can't remember where they were from. Oh my God. But no, I mean, basically, you're quite right. I think the problem is we're still at the stage of throwing everything we can find at it. And clinical trials just take the time they take. We are at least seeing some small randomized ones now, rather than just sort of completely empirical ones, which is good. The problem is because this virus firstly only has a small window of time during which it affects people, the timing with which you apply these treatments is going to be extremely crucial as well. And some may be things that work to dampen down inflammation, so may only be applicable to people who are already hospitalized. Others maybe have an antiviral effect, but the time window you have for exactly when you take that may be very crucial. As with the tail of the COVID vaccine, I don't think that there are going to be any shortcuts to a rapid treatment or a preventative method for this virus. I really don't. And of course, the other issue is, as we saw with SARS and to a lesser extent with Ebola, if our efforts to contain the virus are successful, and with the exception of a few places like Brazil, the epidemic curves are starting to go down in most countries. By the time we've got something that works, we may not have enough people around to do a really big clinical study of it. This is actually what did happen with SARS, and which stopped some of the research with SARS. I suspect that my guess is that this will be an easier virus to deal with than HIV, but given that HIV is one of the most difficult viruses to deal with, that doesn't say a lot. And I get very angry with things that say, we're going to have a vaccine in a few months. No, we're not. Vaccines take longer.
Great.
Okay. Can I bring up something, Simon, that you briefly touched in your presentation? I think we discussed it at length at the CAB meeting on sexual transmission. You talked about not getting new partners, and would you like to expand on sexual transmission of COVID-19?
Yeah, sexual transmission probably occurs because you're within 2 meters of each other.
Yes.
You're gonna have.
You know, and you know, you can try and invent all sorts of creative ways of having sex that maybe doesn't involve coming within 2 meters of each other, but then you're still likely to be in the same room as each other. And at some point, hopefully, you will be breathing a bit more deeply, in which case you'll be
and kissing.
So those two things there, I think, are important. You know, when we're talking to you know, all the people we work with, we have to talk in everyday language and just say, the reality is, as you're thinking about all the messiness of sex and whether that's a risk, but it's not. It's the fact that you're close to each other and you're breathing heavily, and this is a throat infection, and that's where the virus is coming from when you're breathing out, and that your infectious fluid, if you really want to be looking at levels of virus in fluid, is going to be in saliva. So you're very quickly ticking off lots of things in boxes that you might want to do or you might call sex, and so you're not really catching it from the sex bit, you're catching it from saliva and infectiousness and being close to someone. It's a real tough one if you are not hooked up with a partner already or partners already. And I think in terms of the coming out of, you know, we're seeing that the physical isolation is being relaxed and we're coming out of this first wave, and so people will feel safe again, and yet the medical problem is being infectious maybe for 5 or 10 days before you have any symptoms.
Eliane is asking, what about having sex with a mask?
Well, you know, what are you, top and toeing? Are you both 8 foot tall and got strange anatomy? You're going to be breathing heavily. The masks aren't medical grade masks that block out all virus. They limit the spread of infection on a population-based level. You know, so probably the best way to do is to have frequent testing and then isolation. You know, and to trust that any partners that you meet have also been really strictly physically isolated for the last 2 weeks. You know, no contact with anyone for the last 2 weeks, and then you might be able to define, just as in safer sex, not safe sex with HIV, you might be able to define risk circumstances where you're prepared to take a small risk in order to have the quality of life from not cutting out sex altogether. So it will be negotiating and with with the understanding that nothing is going to be 100% safe because someone might be infectious without realizing it.
And Vim is asking, probably making a comment, says 56 Dean Street Clinic says now the transmission chain is broken. Does this make sense for HIV and STIs?
Sorry, can you explain a bit more? You mean the chain between STIs and HIV?
Yeah, the transmission for HIV and STIs chain is now broken. Or Vim, would you like to comment yourself?
Sure. Hey, everybody. No, I was reading, I don't know if you can hear me. I was reading this article yesterday where 56 Dean Street is saying, look, the fewer hookups now during lockdown means there's less chance of infection. So now is the time to test and to stop the transmission for good. Very bold statements, but Simon, you said that maybe there's a backlog of HIV and STI tests. So there's not such a huge drop.
Okay, so you're talking about just purely HIV, you're not talking about coronavirus risk?
Yeah, no, I'm talking about HIV and STIs, that they are talking about that.
So HIV is already becoming pretty scarce in countries that have got access to, certainly if you've got access to PrEP, and most people are diagnosed early and are on treatment, the link between HIV and STIs, or the incidence of HIV is already dramatically reduced. And so you'll have a period where people, there's less STIs transmitted if people aren't hooking up, but then you're going to have, people are going to go crazy. The people are already going a bit crazy, I think. This is not normal circumstances. And so people aren't going to stop having sex just because of coronavirus forever. And so maybe it's good news, maybe it's optimistic, but I think that it's more likely that there will be a backlog of STIs when the clinic services reopen again in 6 months' time.
Okay, thanks.
I was going to just comment, actually, part of the reason I wanted to do this was not because I've got anything particularly great to say. It's just by default I've ended up reading a lot of this stuff, but I also wanted, I'm an EATG member and have been for 20 years, and I wanted to hear back how things are going in your countries and just to see everyone for a bit and have this discussion. So I really appreciate this. And it's easy to stay around if people want to still talk for another half hour or so. I think we've booked a longer meeting, and if everyone's got busy lives as well, if you have to do other things, that's okay as well. So, but I'm happy to stay around and talk for longer if that's useful. How are things? Where are you, Vim? Are you in South Africa?
Yes, I'm locked down in Cape Town in a very strict lockdown. No, there's no sales of alcohol or cigarettes, and yeah, the army's in the streets. But let's see if it will make any effect.
Okay. So Polly reported a study that was modelling on the risk to HIV positive people particularly in Southern Africa, if the downside of coronavirus is interruption in HIV treatment. And IBASE have already had people have questions from people in different circumstances where, in the UK it's okay, ART will always be around, we hope, but I'm getting other calls from people. I had an email from someone in Botswana. They went to the clinic and they didn't have all the drugs. They just got given the nukes. And so this is a serious activist issue as well, like stockouts are a big problem in lots of countries. And the study Polly reported was potential increase in 500,000 people who are HIV positive could die if the stockouts become a real issue for ARVs.
Yes, and well, yes, I mean, the knock-on effects for HIV, but also for TB, malaria, and other drugs is going to be huge. The repurposing of drugs and stockouts and the whole lot. Yeah, it doesn't look good. I mean, you've seen probably the models on how many extra deaths we're expecting in the next years for those diseases. Yeah, fingers crossed. That's all I can say right now.
Thanks.
Any other comments from different countries? Anything you'd like to share?
Is anyone from Germany? Is Ziggy on? Because Germany's actually got really low mortality rate. They're doing lots of testing and lots of testing with self-isolation and stuff, and they got very low mortality.
Yes, Ben?
I really apologize for being a full hour late. I'm really sorry. I don't know what's been said before. I just wanted to report that we were just writing up the results of a survey that we did through ChemSex resources to talk about COVID and the impact on ChemSex. But we did the survey in such a way that we also asked people to talk about the experiences of key populations other than just people doing ChemSex. And what we found is that there were some brilliant exceptions, Georgia being one, for example, Zurich another, Kiev another, places in Russia where people were still maintaining not only expanding testing through home testing or other methods, but were actually maintaining face-to-face testing too under very strict regulations. And it, in Czech Republic, for example, has anybody talked about Czech Republic?
No.
I know that they had tried, the Czech organization there had tried doing, getting home testing and home sampling approved, and had done a trial with the government in, I think, 2018 that had shown to be very effective, but the government still refused to allow home testing. But because of the lockdown, the Czech AIDS organization then went back to the government and got permission to increase home testing. And there's some other examples of that going on. Also examples of people in Tbilisi in Georgia, they organized PrEP delivery through ambulances. So people were getting their services delivered to them. And then when the ambulances were needed for coronavirus patients, they switched it over to other cars. In Zurich, they've organized bicycle teams to deliver drugs, PrEP, other harm reduction materials. So we're hoping to get the report out soon, but it really demonstrates a very wide range of resources that aren't being recognized.
Thank you.
Just to add one thing, I mean, I've been in touch with one of the guys from the Barcelona PrEP clinic, and they've been doing some of the same things. There have been ChemSex parties going on during lockdown still, and they also organised a similar service.
Thank you. Yes, Marianne? I'll unmute you. Okay.
No. I'm so sorry for coming in late. I just arrived, so I just missed the first part of it. But in Norway, now we already came out of lockdown internally, not outside, but inside. Everything is back to normal. Schools are open, but we're still taking care and encouraging people to work from home. Those who can work from home. The only problem that we didn't have a lot of people getting infected with our 5 million population. I think it's around 7,000 people who are infected with the deaths of around 300 people. But the biggest problem was the migrants. This is the most affected group because all the information that came out in the beginning was all in Norwegian. So people didn't get the right information in the language that they mostly understand. And this is why I think our population is the one that got mostly affected by the whole COVID-19, and this, now we are trying to push the government to ensure that in case that there is information in appropriate language and taking into account that we are people who are used to meeting and getting close to each other. I think the information came out very late to us.
Thank you.
I'm sure in most countries as well, lots of countries, some people are disproportionately will be affected by COVID-19 because they don't have accurate information. It's like some of which is our job.
on the survey across WHO Europe, migrants, sex workers, and trans people were almost in every situation identified as those people the most impacted. Like Marion said, in some cases there was no information at all that was appropriate to them early on.
So, open question: how are people finding that HIV? Has your work shifted from HIV? It's like similarly, has it all been dominated by COVID-19? It's almost like everything has been put on hold. This all broke sort of in the week of Croy, and I've reported the stuff I reported from Croy went out then, and I've hardly looked at it since. So you also have that huge volume of information and research and stuff. Everything seems to have been put on hold, and maybe quite rightly. And so I assume everyone else is going through the same thing.
I think one of the things that we're seeing is that you know, the social control measures across everywhere are going to have a real impact upon what comes later. You know, we're seeing more control of people, control of population, control of marginalised populations. There have already been interesting impacts upon criminalisation issues, criminalisation of HIV transmission. And we're putting this into a, it's taken over, and we're having to track all of those things that we were normally tracking around HIV criminalisation, of actually looking at the criminalisation of the way that the response to COVID, which I think is going to have a real serious impact upon taking away some of the gains that we've made in terms of HIV criminalisation in several countries. We're producing a newsletter about it, but it's taking up an incredible amount of our work.
Yeah. And if the whole world falls into an economic depression, or majority of it falls into economic depression, then you know, poor and marginalised folk suffer the worst. And so we need to be looking ahead all the time, because the social impact of the economic depression is going to be really seriously felt. Numbers of people that have lost their jobs and been furloughed without pay, and it's going to be terrible. Sort of to the extent that actually the health bit falls off the scale, you know, because you haven't got, you're worried about if you can pay your rent, and if you've got, you know, you can buy food and stuff. I'm trying to be optimistic, but I'm finding it difficult. Yeah.
I want to talk about the sort of, has my HIV work stopped? In my case, no, because some of what I'm funded to do is funding that lasts till next year. That's an uneasy feeling, because you're aware we've already had one grant for prep work withdrawn because the organisation felt it had to sink its funds into COVID instead. I'm taking, certainly my sort of background as an HIV treatment activist and advocate means I'm taking a lot of interest in the COVID research, but I'm trying to sort of be faithful to HIV, as it were, and only stick up stuff that's got HIV relevance, because HIV will be around when COVID has gone, or to some extent has at least been contained, I think. And people, you can't keep people in lockdown forever. They are going to go back and have sex. One of the other things we were talking about in, as well as what Julian's already mentioned about sort of COVID, anti-COVID measures being used as cover in some cases for reviving HIV criminalisation issues, is also people finding that the sort of the kind of tolerance of people's different lifestyles that HIV prevention work has educated healthcare workers to adopt can in some cases be a bit thin, because people have had experiences of either going along to a clinic saying I need a test for an STI, or just sort of talking to healthcare workers and admitting that they were still having sex during the COVID epidemic and getting extremely unsympathetic and, you know, abstinence-focused answers. So I worry that we'll have to reconstruct quite a bit of that work when the current emergency is over, and I'm sure some of the rest of you have had similar experiences.
So the UK CAB's doing a survey where we ask about whether people feel like confident in seeking sexual health services if they've got a need to, you know, like if you need emergency contraception or if you need sexual health services, and so I'm sure all those things will be important, and I think that the response in order, like UK is trying to do contact tracing again now, they're going to sexual health clinics because they're one of the few places where people can talk in a reasonably non-judgmental way about confidential issues, and so lots of our health advisors are being absorbed into the COVID-19 response that way.
Yes, okay. I can't pronounce your, no, wait, Ben.
I saw Bogdan raise his hand. Go ahead. I'll wait for Bogdan.
Okay, Bogdan, so I'm unmuting you. Okay.
To see you again. This is a nice presentation, Simon. That was a very great, and guest. That was a perfect presentation. We're asking for that. I have one question. For COVID-19, for patients to infection HIV, to have another disease, for example, to problems rheumatics. It's we contact to infection COVID-19. That we have to risk more for problem to people to have disease to rheumatic, that we have a possibility to aggressive like contact first.
So in terms of prioritizing risk, which one bumps up the list or bumps down the list, I think any complications for breathing or lung problems are a really high risk for a worse outcome for coronavirus. So if you have asthma, if you have COPD, that's a reason to take self-isolation even more seriously, be super cautious about everything that's going on. And I don't think HIV being on treatment will have any impact at all in that person's risk. If that person doesn't have an undetectable viral load, then you're adding in an immune inflammation state, and then it would be important. So.
Yes, because for example, I'm have a disease like this, a rheumatic. My leg, we have enough possibility to move more, and that I'm a patient for HIV and comfort in the many years. And then we have these questions important like that, because that we take a medication for rheumatics, and I have a thinking, so probably contagious of coronavirus, that we have it's really scary, not scary, and we have impact, it's low, not aggressive like that. That's why I question, Simon, because this is the most important for me, like we have a protection for this coronavirus.
So if your health condition is controlled, if you're taking medication that means that it's actually not an active infection or it's not an active problem, then you should be okay. You won't be at higher risk. It's just uncontrolled. You know, like if you're on heart medication or medication for asthma that's not controlling your asthma and it's making it a breathing problem, then your risk is increased. But there's anti-rheumatoid drugs that are being tested for COVID-19 because they're anti-inflammatory. So if you're on,
I will get these anti-inflammatories like that. But
so that might reduce your risk of coronavirus being serious because you're already being pre-treated, like a sort of prophylaxis for coronavirus. So I think the plausibility there is that your risk might be reduced. I'd still be super cautious. I wouldn't go around, you know, I would try not to catch this virus for as long as possible. And our strategy should all be to try and, you know, like with HIV, we aimed to be there when the drugs came because we knew they would come. With coronavirus, we want to be here when the vaccine comes or when an effective treatment is discovered so that we are okay when that happens. So everyone now is in a window period because until we have active treatment or an active vaccine where the best advice is to really minimize your risk of catching this thing. Because if you're unlucky, I don't care that 80% of people are fine, great for them. I always think about the percentage of people who have complications. You know, the issue about pediatric complications from COVID-19, you know, some kids have a really terrible response to this. It's called like Kawasaki-like viral infection. And so it's not safe to just say all children are protected. And so be careful, minimize your risk, take self-isolation very seriously, and, you know, wear a mask when you go out, and, you know, and be careful with your contacts and things.
Yes, because in Romania we not see a report for prime ministers to healthcare. We not see a report to have a patient infection to coronavirus, for example. Yeah. We don't see anything a report for in Romania. They have a patient to infection HIV and they will contact to coronavirus. I don't see that this report like that.
Okay, so
sorry.
So you will become the source of information.
Yeah, thank you so much for information. Thank you.
Oh, just to ask Bogdan, were you asked to shield in Romania, in the UK, for anyone with like certain conditions like asthma, or, you know, I'm a solid donor. I had a kidney transplant, so I got a letter from the NHS, the government, to say I must stay indoors for 3 months. I must not with my own family. I must not go out and so on. I wonder if you got that in Romania.
All right.
You get that? Were you advised that in Romania?
I don't see like this is a report like to people living the infection HIV and they will contact to coronavirus in this moment. And I will see it to report, for example, ACDC and other organizations, the prime ministers, the healthcare in Romania. They don't see exactly what impact to people infection HIV they have to risk to impact to coronavirus. I don't see like this. That's why these questions you can follow like this to report, because me, I don't see like that this information.
Okay, so there is something I'd like to say about HIV. And treatment with coronavirus is that if you've not been diagnosed, your situation is going to be much more complicated. And so some of the doctors in the UK and activists have been trying to get the coronavirus units, the intensive care units, to make sure they ask if someone's HIV positive. And if they don't have a recent negative test, to test them. Because we've had examples where people who don't know they're positive and they've already low CD4 count have been, you know, they've been hospitalised with PCP infection, and the PCP has been missed, so they've been discharged back home because they think it's just coronavirus, and then the outcome's been very bad. So there's at least one case where someone's died because HIV diagnosis was missed. And so it's a really important time as HIV activists to make sure that the health systems that are dealing with coronavirus don't forget about HIV and include HIV testing. And that certainly will overlap with migrant populations where late diagnosis is still an issue.
Elaine,
okay, thank you. Thank you so much for the questions. Thank you.
Elaine?
Yeah, hello everyone. I want to share something on healthcare here in Netherlands. When coronavirus started and we got, I am also a patient with diabetes and had blood pressure. So we receive emails from the GP. We normally do control our diabetes by GP and also blood pressure every 3 months by our family GP. But then we got emails that we're not allowed to do that anymore. We need to do it ourselves at home. But when I try to see, of course, there is also a problem of language, also from migrant. If I have to see how many people who received that email, and most also were also older people. Old people goes to GP for control for diabetes and blood pressure. They also received that email. And as a person living with HIV, of course, that's extra worries for me, because if I cannot keep all the checks up as normal it is, it brings me a little bit of worries, and I have to say I'm not the only one. There are also more people, so that's a problem now, and we kind of being left behind. We are dealing with the HIV, and even if you have your HIV, you are just undetectable, and there are other diseases coming in, and you are not able to know exactly all the checks up. It's kind of yeah, put you also into a social and emotional stage.
So yeah. Is your HIV viral load undetectable?
Yeah, luckily in January, that's before lockdown in Netherlands, I have been to see the HIV doctor, and I did get a result. My CD4 account was 634. So, and I was undetectable. So this that's good news from January. I heard that.
So I think the lack of HIV monitoring is not a big problem.
No, it's not a big problem, but retrieving all information around makes you question yourself. Like, for example, when I go in a supermarket and I try to keep a distance, and there are people coming to bump you on purpose, you just think like, yeah, it's not because of HIV, but I have other risk factor that may affect me. So then you think like, so yeah, that's something that I need to share with you here.
Yeah, and is your diabetes controlled?
Like
your blood sugar, is it stable, or do you need to do that?
I don't have I cannot control my blood pressure myself. I'm supposed to do it by the GP because I don't have the equipment.
Yeah.
And I'm supposed to see my diabetes next week, but I got a letter. I'm not allowed to see her, but then I need to check on me on the finger, and when you prick on the finger is not enough. Then when they take like 3 months to check really the whole level. So for now I use the one to test on the fingers, but it's not enough. But I try my best to stay healthy as possible.
Okay, it sounds like you're doing the right thing, and it is really disorientating. You know, you have these appointments booked in the future, and they all get cancelled. Including people in the UK who are being treated for they're midway through cancer treatments.
Yeah, I have already 22 years with diabetes, but now with this, when they check everything, and I have like 4 appointments in the hospital, they all canceled them that they're gonna call me. But then it's not same when you have to go and give blood in the lab. You cannot do a lab, and then I'm thinking like, yeah, what is it now? Yeah.
Okay, so hopefully with the first phase will start to be relaxed, and it'll be easier to go back to routine appointments. And it sounds like actually you're very experienced and you're being very well monitored, and that you're pretty stable on all these health things.
Thank you, Gus. I'm aware of time. Gus, would you had your hand up? We
Okay.
have a few more minutes to go.
Yes, I mean, I think certainly in the UK, the whole issue about the letters being sent out to people with at high risk of COVID was very badly handled. I got mine for a start about a month after lockdown, which would, in other words, have been no conceivable use to me if I had been at high risk of COVID and been out and about. But it also sort of, it explained that I was at very high risk of COVID and gave a whole list of things, a fairly comprehensive list of the conditions for which they were sending people these letters, and HIV was not on that list of letters, a list of conditions, and I don't have any other conditions. I mean, unlike a lot of people here, I'm pretty fit for my age, other than being a long-term survivor of HIV. And I think the whole thing was handled very badly, partially because it told people that they were at risk for HIV according to the government. They were at risk, sorry, I keep mixing the two things up. They were at risk for COVID because they had HIV, and the government was telling them this. All the data seems to indicate that HIV alone doesn't put you at greater risk. Secondly, it came out too late. And so I think the whole thing was very badly handled. And of course, it doesn't, especially if it was coming out too late, then it doesn't really help people who do have risks for COVID, like I know several people here do. And also, I mean, in terms of like hospitals, you know, hospital appointments being cancelled, I think, yes, I don't need to see my doctor every 6 months to tell me I've got an undetectable viral load. But I certainly had a moment's insecurity at not being able to have that 6-monthly reassurance that I'm doing okay. And the fact that I won't get a blood test for anything when I go and when I have my phone consultation with my HIV doctor. So that's how I feel about it.
Thank you. I think we should come to a natural end, unless if there are any burning questions. And just to say thank you very much for everyone for taking time out to join us and share your experiences, ask your questions. And I hope this is useful. As we said earlier, the video was being recorded and will be shared on the IBES website and other social media outlets. Thank you, everybody. Hope to see you again soon.
Yep. Thanks to EATG for organising this, and thanks, Memory, and it's fantastic to see everyone. Right, so.